Hello everyone. Pancreatic neuroendocrine tumors are rare, but they are clinically fascinating entity. One patient may present with recurrent hypoglycemia and seizure, another with refractory peptic ulcers, another with liters of watery diarrhea, and another with silent pancreatic mass with liver mets. The key to understanding PNETs is simple. First, decide whether the tumor is functional or non-functional, then localize it, grade it, stage it, and plan the treatment. In this video, we will simplify the PNETs for medical students and trainees. So this is a very basic level talk meant for the trainees and basically medical students, from clinical presentation to investigation, prognosis and management. So theoretically, then some case discussion and questions, so that this will be a comprehensive video covering all the aspects of PNETs. Please read the detailed disclaimer and description. These videos are meant for education purpose only, and these are not a substitute for professional training and professional advice. And friends, for an exclusive and early access to our premium high definition content, please download our app Android or iOS or join the channel membership. The link for everything is given in the description of this video. Please check it out. So in this series, we have already uploaded few videos about the general NEC, basically non-functional NET, Insulinoma. Please check them out so that you have a better background knowledge of this entity, the things we have already discussed on our YouTube channel and on our app. So now let's start with this PNET episode, Clinical Features, Investigation, Prognosis, Management 2026 update. So friends, the principle of investigation is simple for the functional PNETs, that you have to basically look for the hormone that produce like insulinoma, serum insulin, C-peptide, pro-insulin during hypoglycemia. And for Gastrinoma, fasting serum gastrin level more than 1000 picogram per ml and gastric pH. We got diagnostic, Glucagonoma, elevated fasting glucagon levels, Bipoma, elevated plasma BIP levels, and for Somatostatinoma, elevated plasma somatostatin level. For non-functional PNETs, the chromogranin A is non-specific, but usually it is a helpful adjunct and helpful tumor marker for the non-functional PNETs, and you should always look for it. So what are the imaging required for diagnosis? So first line investigation will be CT scan, triple phase or MRI. That is the first line imaging modality to detect size, location, metastatic spread of tumor. Look for liver mets, which are common. PNETs, pancreatic neuroendocrine tumors, are hypervascular, best seen in the arterial phase. Just remember this thing, that they light up in the arterial phase. So always look for these tumors in the arterial phase and look for the enhancement pattern. So this is the CT scan image in case of non-functional neuroendocrine tumor. So you can see there were large mets. Patient was asymptomatic, and during routine screening, these tumors were detected. Look at there are areas of necrosis because of the very large size, multiple tumors. Look at the enhancement pattern in the arterial phase, how well they are enhancing in the arterial phase. Some more pics of the same patient. Look at the size, and patient presented with these mets. This was the first presentation. So as I said, the non-functional PNETs remains asymptomatic unless they acquire a very large size or they are basically multiple mets. For evaluation of the PNETs, the endoscopic ultrasound has very high sensitivity and is very good positive detection rate of more than 90%, and also along with the ultrasound it allows for the fine needle aspiration biopsy, so can detect tumor as small as up to 2 to 3 mm. So in the diagnostic algorithm, EUS has a very good and significant role. Other thing will be they are usually express the somatostatin receptor. So we use radio labeled somatostatin analogs. So PNET that express somatostatin receptor useful for the staging and detecting metastasis. So now we have very good PET scan modality, that are the DOTA PET and DOTA NOC. So we have specific basically ligands. They target these lesions, and they detect somatostatin receptor expressing PNETs, highly sensitive, highly specific. And for any PNET rising from any site, maybe it is a lung or it is the basically the GIT or the pancreatic, the gallium DOTA scan or DOTA NOC scan is the gold standard for diagnosing the pancreatic neuroendocrine tumors. So this is the gallium DOTA scan of the same patient. Look how beautifully, I think it is extending scan, a better form of the DOTA scan. How beautifully these small lesions, large lesions are picked up on these PET scan studies. Some more pics of the same patient. If despite all the measures we are not able to localize the tumor, then the angiography is very good modality for preoperative localization, or in case where imaging is inconclusive, PNETs are hypervascular, appear as a tumor less on the angiography as shared in these pics. So this is the diagnostic imaging ladder. Ultrasound, maybe CT scan, MRI, first choice. Endoscopic ultrasound, it has a advantage that you provide the tissue diagnosis also. Disadvantage is inclusive. SSR, somatostatin receptor study, they are outdated. Now the DOTA or DOTA TET, DOTA PET scan, they are the gold standard. And last is the angiography if rest of the modalities are inconclusive. The final diagnosis is with the biopsy, that is obtained from the US or FNA percutaneous route, and IC is confirmatory, that is you look for the specific ISC marker like chromogranin A for these tumors. So again, this is very important slide in the diagnostic ladder, friends. Just try to understand that the well-differentiated pancreatic neuroendocrine neoplasm, pancreatic neuroendocrine tumors, PNETs, they are basically three grades. Grade 1, when the Ki67 index is less than 3 and mitotic indexes on histopathology is less than 2. So on ISC less than 3, less than 2. Grade 2 is 3 to 20 is Ki67 and 2 to 20 is mitotic index. So in mitosis size is 2 and on the Ki67 it is 3. For grade 3, it is more than 20 and more than 20 proliferative index and more than 20 is the mitotic index. So next term is pancreatic neuroendocrine carcinoma, that will be grade 3. So P always confuse between the pancreatic neuroendocrine carcinoma and pancreatic neuroendocrine tumor grade 3. So what is the difference? So when the architecture is preserved, then we grade it according to the pancreatic neuroendocrine tumor grade 3. For when the architecture is lost, when the histopathologist or the pathologist will say, it is basically there's no clear picture whether it's an adeno or it is a neuroendocrine, I cannot say. So then it is usually a picture of the neuroendocrine carcinoma. So that will be grade 3. There are no other grades for NEC. They are basically two types, small cell type and large cell type. In both these scenarios, the Ki67 and the mitotic index is more than 20. So you can pause this slide here and try to understand the difference between the NET grade 3 and NEC grade 3. So the prognosis for grade 1, grade 2 pancreatic neuroendocrine tumor is generally better. Localized grade 1, grade 2 PNETs, 5-year survival rate is 60 to 90%. Tumor less than 2 cm, there is a low risk of the metastasis. For grade 3 or the neuroendocrine carcinoma, they are poorly differentiated, more aggressive with a worse prognosis. And for the grade 3 tumors or neuroendocrine carcinoma, the 5-year survival rate is generally less than 30%, specifically with the METs. So friends, just remember that the tumor grade is based upon the Ki67 index and the mitotic index. As I said, mitotic index is less than 2, 2 to 20, more than 20, and Ki67 is less than 3, 3 to 20, and more than 20. Stage is localized versus metastatic, functional versus non-functional. Functional tumors may be detected earlier, the prognosis is better. And metastasis, liver most common site of the METs. Presence of liver METs worsen the prognosis. So now let's discuss the management part. So friends, the treatment of choice for all localized pancreatic neuroendocrine tumor is surgery. So whenever we can take out them, we can achieve the all the tumors can be taken out. Surgery remains the choice of the basically treatment. For less than 2 centimeter tumor, functional PNETs, low magnitude potential, enucleation can be done. For like pancreaticodenectomy for tumors in the head of pancreas, or distal pancreatectomy, tumors in the body or tail, liver metastatic resection if liver metastases are limited, or cytoreductive surgery in case of extensive disease. Debulking surgery can be considered. Again, do remember, sir, this is a bit debatable. The primary treatment of choice is surgery whenever we can take out the whole disease. So friends, in general, resection is advised for all the functional symptomatic PNETs. Localized grade 1, grade 2 PNETs more than 2 cm, less than 2 cm, they can be observed. Metastatic disease, they may be considered for the resection if all the visible mets can be resected. Palliative resection of primary and hepatic debulking may be done. It be used to done in past, but the survival advantage remains unproven. We have to choose these patients very carefully, case by case decision. Enucleation may be considered by PNETs when they are away from the MPD 2 to 3 away. The tumor size is less than 2 cm, localized and located relatively nearest to surface of the pancreatic parenchyma. In addition, intraoperative ultrasound may be used to visualize location of PD during the procedure. So this is again a picture of a patient with a large multiple lesion in the liver from the NET. So we try to do all the debulking. All the tumors were taken out. This is again non-functional tumor. The images of the DOTA and the CT scan I have already shared in the previous part of this video. So this is the resected specimen and the intra pictures of the resected tumor. Cut section of the tumor. Look at the highly vascular tumor and areas of necrosis in between the tumor. So these are the gross specimen images. The tumor is solid cystic, variegated in appearance. Multiple areas of hemorrhage are seen. So these are the basically IC marker, chromogranin, non-specific esterases, synaptophysin, Ki67, CK and CD56, which are helpful in the diagnosis of the neuroendocrine tumors. So as I said, the somatostatin, which is the inhibitory hormone in the body, so it becomes a treatment modality for all the other PNETs. So it's basically analog like octreotide and lenalidomide. They control hormone secretion in functional PNETs, inhibit tumor growth in somatostatin receptor positive tumors. So that's the rationale behind giving the somatostatin analog for all these PNETs. Other alternatives are targeted therapy in the form of everolimus, mTOR inhibitors for advanced and progressive PNETs, or sunitinib, that is a TKI inhibitor, advanced cases, particularly non-functional tumors. For the advanced or high-grade PNETs, streptozotocin-based regimens like streptozotocin and doxorubicin, or alternative regimens like capecitabine plus temozolomide. So you just remember these names, otherwise these fall under the domain of the oncologist. So for localized disease, surgery is the treatment choice. For metastatic disease, systemic therapy is the treatment of choice. So try to understand the PRRT, that is the advanced modality of treatment for metastatic unresponsive pancreatic neuroendocrine tumors, peptide receptor radionuclide therapy. So basically that can be used for the tumors which express the somatostatin receptors. So like in this picture, there is a tumor cell which has this somatostatin receptor. So we basically ligate a radionucleotide, that is the lutetium, to the somatostatin analog, and so this is one ligand which will attach to the target organ, and there will be localized form of the radioactive isotope is delivered to the tumor. So this is localized form of the radiotherapy. So if the treatment is not curative, then you have to give it symptomatic. Like Insulinoma, you can give digoxide that reduce the insulin release. Gastrinoma, high dose proton pump inhibitors for controlling the acid secretion. Glucagonoma, treat hyperglycemia and malnutrition. For bipoma, you have to manage the dehydration and electrolyte imbalance. The follow-up, these patients require regular imaging, CT, MRI, PET to monitor recurrence and progression, biochemical monitoring in the form of the chromogranin A or the specific hormone that it was producing. So friends, the key points are early detection, accurate grading, multidisciplinary approach, surgery, if not then medical therapy or PRRT, critical for effective management of PNETs, functional PNETs present with a distinct hormonal syndromes, so you can direct the investigation accordingly and diagnose them. Non-functional PNETs may be discovered incidentally, can grow large before becoming symptomatic. So this is the small algorithm. Less than 2 cm, grade 1, grade 2 tumor can be observed, or as per the patient wish, they can be followed up. Or for grade 2, you can offer the surgery also. You can do EUS MRI every 6 to 12 months. If no change, then increase the surveillance more delayed. If there is increase in size more than 2 centimeter, do the surgery. For more than 2 centimeter tumors, usually surgery is indicated. And for high grade or NEC, systemic platinum based therapy or the PRRT may be considered. So now I will give you some clinical scenarios. Some are basically real time, some are not so real time, imaginary. So you have to pause the video at times, make your diagnosis, then move to the next part of the video. So first is case number 1 is classical presentation, real life case. So that means this case was managed by us. So this 44-year-old lady homemaker presented with episodic sudden loss of consciousness for last 5 years, history of generalized tonic-clonic seizure, symptoms amyloid after taking sugar, evaluated in local hospital, found to have hypoglycemia. There was no history of loss of appetite, weight loss, no history of jaundice or GI bleed. So what it can be? So this patient was evaluated extensively for the psychiatric illness because she was becoming unresponsive or there was a confusion symptoms at times. There were no other positive history and she consumed mixed diet and her family history was not contributory. So this patient was started on bisolone, I think, for the hypopituitarism. There was some improvement in the symptoms, maybe because of the hyperglycemic effect of the steroids. Then she was evaluated in the department of endocrine, managed with dioxide, starch-based, corn-based diet, and blood sugar monitoring. And then after that, she was referred us for the surgical evaluation. So dioxide, as I said, it suppresses the insulin secretion and is symptomatic management for the hyperinsulinemia by direct action on the beta cells. So I hope the diagnosis is itself clear from the history. On examination, patient is conscious, comfortable, oriented, and alert. BMI was 27.5, 6 kg per meter square. As such, she was on the overweight side. So they learned to eat to survive. The general physical examination was normal, abdominal examination was normal, and rest of the systemic examination was normal. So this patient was evaluated for basically insulinoma and MEN work was done. Those rest of the marker like cortisol, the TSH, ACTH, GH, serum gastrin, PTH, prolactin were normal. Her fasting blood sugar was found to be 35, and the serum C-peptide was 3.01. The insulin fasting level was 14.10, all indicating towards the basically insulinoma diagnosis. The rest of the parameters were normal. As I said, the ME1 workup was normal, so it is not a syndromic insulinoma. You have to read this, otherwise ME1 you have to read parathyroid, pancreas, pituitary, foregut. All these things has to be evaluated while you are suspecting a diagnosis of ME1, specifically in the case of pancreas, insulinoma, gastrinoma, and other tumors. So this is the investigation this patient was done. Ultrasound was normal, MRI cranial, think of the psychiatric illness, it was normal. Triple phase CT was normal. I'll share the pictures and then the picture will become clear. Otherwise they reported no pancreatic as well. So this CT scan, triphasic CT scan of the abdomen of this same patient was reported normal. So when we were seeing the pictures, I hope you can make out, you can see there's a subtle bulge with the enhancement in the superior surface of the pancreas, just distal to the neck. In this single picture, this enhancement and bulge is even clear. Same is here. So I hope you could make out. This is a labeled CT scan image. So there's an arterial enhancing lesion noted, the bulge missed out, that was missed out on the initial CT scan. There's the MPT was prominent just below the bulge. Portal vein and rest of the splenic vein were normal as marked. So hypervascular to the normal pancreas and arterial and pancreatic parenchymal phase. This is highly suspicious for the neuroendocrine tumor. This patient was planned for the PET scan. So as I said, the DOTA scan, the DOPA scan, DOTA TET, DOTA NOC, they are specific of the pancreatic neuroendocrine tumors. And latest addition is 68 gallium exendin scan. So on that scan, there is a Very good uptake as seen on the left side of the picture. The upper is the DOPA scan, lower one the Exendin scan. Look how beautifully it is enhancing with these scans. And on normal CT scan, there is any only subtle bulge. So that is how these investigation DOTA, DOTA PET, Exendin, they have become the gold standard now for the diagnosis of these neuroendocrine tumors. The diagnosis is insulinoma, classical presentation. So in this case, we did central pancreatectomy with root by pancreatic neuroendocrine for this lady. So there were no other lesions. There were mass in the body of pancreas. We did central pancreatectomy. The proximal part was cut with the help of stapler. Distally, we did the PJ, root by PJ with dunking method. So these are the basically diagrammatic representation what we did for this patient. Central pancreatectomy with root by pancreatic neuroendocrine for the distal stump in a dunking manner. So these are the intraoperative pictures, and the vascular tumor is evident. This is the resected specimen. So friends, the key points in this case are this is a typical case of insulinoma, most common functional PNET. The classical people tried was there, hypoglycemia, documented low blood glucose, and relief after taking the glucose. 72-hour fast test. Diagnosis can be confirmed by drawing plasma glucose, insulin, C-peptide, proinsulin level during 72-hour fast. This panel will detect 90% of insulinomas. Key to diagnosis: serum insulin, proinsulin, and C-peptide. More than 90% insulinoma are solitary, benign, and surgical resection curative. Like in this case, the differential diagnosis you have to remember is factitious hypoglycemia and dumping syndrome. In factitious hypoglycemia, patient will be taking injecting insulin in him or herself, but that can be picked with the help of proinsulin and C-peptide. So friend, this is the next case number 2. Again, the rule is same that you will analyze the case before moving forward and make your diagnosis based on the discussion we already had in this video. So friends, 42-year-old male, the history of multiple recurrent peptic ulcers and severe GERD, presented with abdominal pain and chronic diarrhea. So patient reported to have peptic ulcer disease for several years. He was taking PPI around the clock, which were unresponsive to high dose of PPIs, also complaining of chronic diarrhea and weight loss. So the serum gastrin, which was 2000 picogram per ml, markedly elevated. The gastric pH was less than 2, hypersecretion gastric acid. Secretin stimulation test further increased the gastrin level. Imaging CT and MRI, 2.5 cm mass in the head of pancreas. PET scan, positive uptake in the pancreatic mass. A metastatic lesion in the liver. So the diagnosis is itself glaring. It is Gastrinoma or the Zollinger-Ellison syndrome. So we manage this patient with the surgical resection of the pancreatic mass with the liver metastatic debulking, and patient was also managed with the high dose of PPI. Post surgery, serum gastrin level decreased, and symptom of the GERD and diarrhea improved. So we did the resection plus the metastectomy. Coming to the case number 3 now with liver mets. I hope you can make out the diagnosis with this line only. So a 60-year-old man presented with vague abdominal pain, unintentional weight loss, and early satiety. There was no significant past medical history. He also gave history of this non-specific discomfort, pain for last several months without any other positive history of jaundice or upper GI bleed. So we evaluated this patient on ultrasound. There was a suspicious lesion in the liver and tail of pancreas. CT scan abdomen showed 4 cm mass in the pancreatic tail, multiple lesions in the liver, so history of mets. Chromogranin A was elevated, non-specific marker of the NET, so it was elevated around 170. Biopsy of the lesion confirmed NET, non-functional. Ki67 was 5%, so it was a grade 2 PNET. So, it is a non-functional PNET with the liver mets, but can be the management, friends. Just plan management for this patient before moving forward. So, this is a very extensive disease. There are multiple liver mets. The primaries, the debulking is not possible in view of the extensive liver mets. So this was patient was treated with somatostatin analog octreotide. There is a octreotide depot injection comes, which patient can take every monthly. That control the tumor growth, and later this patient was expected to the PRRT, that is peptide receptor radionuclide therapy. And with that, patient showed partial tumor response. Disease became stable and symptomatically patient was better. Patient is on a regular follow-up. So, non-functional PNETs, as we discussed, they are often diagnosed late, usually with meds. They do not produce any kind of specific type of hormone, so the detection is delayed. And presence of liver mets at diagnosis often dictate the therapeutic approach, because if they're solitary met, or if we can take out the most of the disease, then we can offer the surgery. If there are multiple bilobar involvement, then usually the medical management is the choice of treatment. Coming to the fourth case, friends, this is a rare presentation. So, 45-year-old lady presented with rash, weight loss, and new onset diabetes. So, if you have gone through the video so far, you should be able to make the diagnosis with these two lines only. She complains of itchy erythematous rash on her lower abdomen, thighs, unintentional weight loss, polyuria over past 6 months. There was a rash, polyuria, and unintentional weight loss. I hope you could make the diagnosis. This was something similar to the case which was published in NEGM, which we have discussed, that is the necrolytic migratory erythema specific rash with diabetes mellitus. Polyuria was because of the diabetes mellitus and unintentional weight loss. So this is a basically case of glucagonoma. So these were the investigation. Fasting blood glucose 189, mildly elevated. Serum glucagon level was 1500 picogram per ml, elevated. Skin biopsy rash shows necrolytic migratory erythema. Imaging MRI of the abdomen shows 3.5 centimeter mass in the pancreatic body. So the diagnosis is glucagonoma. So we did the surgical resection for this patient. The diabetes was managed with the help of insulin in the pre-op stage. Nutrition was improved. Post-op stage, glucagon level normalized, rash resolved, and diabetes was well controlled post-surgery without insulin, and the rash did not occur. So the key points for glucagonoma is it's a rare PNET, extremely rare. I think less than 400 cases reported so far in the literature. There is a characteristic rash, necrolytic migratory erythema, and weight loss, mild diabetes. Recognizing skin manifestation lead to the early diagnosis. So, like in this case, the skin biopsy of necrolytic migratory erythema was diagnostic. So, this is the case number 5, last case, a life-threatening presentation. Again, you should be able to make diagnosis based on this one line. So, a 50-year-old man presented with profuse watery diarrhea, dehydration, and muscle cramps. So, on the history, patient was having watery and non-bloody diarrhea for several months with up to 10 liters of stools per day. There was a history of significant weight loss, episode of muscle weakness. On investigation, the serum BIP levels were markedly elevated. Blood test shows hypokalemia, metabolic acidosis, and dehydration. Imaging CT scan revealed a 5 centimeter mass in the pancreatic tail. Diagnosis is BIPOMA, the Werner-Morrison syndrome, or WDHA, watery diarrhea, hypokalemia, achlorhydria syndrome. So, patient was managed with aggressive fluid and electrolyte replacement. Octreotide was started to basically antagonize the action of hormone. Surgical resection of tumor was performed after stabilization, and post-operatively diarrhea resolved, electrolyte levels normalized. The key points are BIPOMA caused profound watery diarrhea leading to severe dehydration, electrolyte imbalance. WDHA syndrome we have already discussed. Timely diagnosis and management with somatostatin analog and surgery crucial. So watery diarrhea, hypokalemia, and achlorhydria, WDHA syndrome, or the Morrison syndrome. So now friends, this is the end of the discussion. After that, so if you have any doubt or any question, you can always ask in the comment section on YouTube or in the chat option on the app. So we will be happy to answer whenever whatever we will share with you. So with that, friends, we have reached this end of this video, and I hope we have added some new insight, new knowledge to your existing vast knowledge. So thank you very much, friends, and we wish you a happy learning. And for an exclusive and early access to our premium high definition content, please download our app or join the channel membership. The link for everything is given in description of this video. So we will don't forget to like and subscribe to our channel. We will come up with more knowledgeable videos. Stay tuned. Happy learning.